Today we'll talk about bradycardia and try to hopefully make it more engaging with everyone. Uh, in the past, I still always remember one of our interventionist cardiologists, and I was gonna give the talk, and he's like, for me, he said, as an interventional cardiology, if it's slow pace, if it's fast, shock. So I'm trying to go deeper than this slow pace. So the first portion is when you have a slow heart rate. Number one, it could be your sinus node, and you can have all those options of sinus arrest, sinus exit block, Mobus type 1, Mobus type 2. Sometimes it's hard to recognize that patterns. Mobus type 1, you will see the P wave happening earlier and then the drop. Mobus type 2 is all of a sudden is not firing on exact perfect timing. And but most of the talk will be about the AV node and the Hesper-Kingi system, and briefly, if we have the time, to talk about the retrograde conduction, because it can be confusing sometimes. But for the second degree AV node, there is that first degree that we're all familiar with, and we're probably many people are familiar that some of our EP giants, Dr. Josephson, and they did not like the term of its AV block because there is a conduction, so they want to call it AV delay. So that's why I put it in parentheses for the AV block. And there is Mobus type 1, rarely Mobus type 2. It can be in the AV node, but it can, and that's important pattern to recognize. And high-grade AV block and a complete heart block. And number three for Hesper-Kingi, it could be intrahesian or infrahesian. Intrahesian is the less, common type. So now the first, very brief about anatomy, and we're going to talk about, some of the etiology, and then we'll go with examples. You have all the sinus nodes, and give that morphology for the P waves of a negative PR, negative AVR, and a positive in 2,3 AVF for the common pattern. And there is a connections through that, to the AV node, to the left in three, if you want to call it electrical cables or bundle, but the famous one to the left atrium is Bachman bundle. A P wave, duration usually 80 to 100 milliseconds, a little bit more it can be, but that's the normal duration. And it's very important, number to, you know, to know there is the shape of the P wave. It can tell you about the delay and what is the delay. For the AV node, it's in the RA endocardium at the apex of the triangle of Koch. Let me this. And this is a very important triangle, for the slow pathway, fast pathway, when we're dealing with a septal accessory pathway for ablations. It's one of the most, probably busy electric, for EP area to recognize. The normal AV junction, it can be divided into the top portion would be similar, more some atrial tissue. The second portion, that is the true AV node, the compact AV node, and then the penetrating part of the Hesper-Kingi. And, on the top, closer to the atrium, kind of tissue characteristics. In the middle, the AV node, and the lower one is more the Hesper-Kingi system. And that's the nodal one, the end cells, which is again the AV compact. That has the decremental properties, which is a very important part. And without it, most of us will not survive like an AFib, because your heart rate will be 300 or 400. So it's one of the most important characteristics for this AV node. And it is the only normal electrical connection. So anything beyond the AV node, it will be abnormal. Like you have this accessory pathways, is it atrioventricular, atriovesicular, but everything has to go through the AV node. And the main function, as we said, is that decrement. So it's decide how many impulses going from the atrium to the ventricle. So that's probably the most number one why it's life-saving, because it controlled that rate. And number two is which characteristic for it, and it's also life-saving. It can be actually function as subsidiary pacemaker. So if your sinus node is not working, it can be that escape rhythm with that automaticity and work as an independent pacemaker when you have very, very dysfunctional sinus node. The AV node is both has cholinergic and adrenergic, and both of them can affect the conduction of this AV node. Adrenergic, more downward conductions, faster conduction, and the cholinergic will slow that conduction. Blood supply, it comes from right coronary artery, almost 90% of the time. The circumflex is 10% of the time. That's why it's easier to get, if you have an MI, to get an AV block first from it. Versus the Hesperkinji system, we said it is after you pass this penetrating portion from the AV node, you reach the first portion, which is a 1 to 2 centimeter. It is the non-branching portion. Then it goes to the right and the left bundle branches. And this is the area becomes hot initially for his pacing. And then we moved away from that and we moved to the left bundle branch pacing. The reason for that is this area is very capsulated and unreliable in having like persistent threshold and sensing. Again, the Hesperkinji system has proximal area and the distal area. The proximal area behaves similar to the AV node. The distal area more the bundle branches. And if you have an escape rhythm coming from that, if you are in the proximal area, your heart rate will be more likely to be the narrower, more likely to be the faster, like the 60. If you are in the distal portion of it, then your heart rate will be the wider in that possibility, and also the more importantly, the slower. So when you see a 40 beats per minute junction escape rhythm, think about it coming, in the lower portion of that junction. It has a dual blood supply, from the descending artery, the LAD, from the left anterior descending, there, and the PDA. And because of this dual supply, it is harder to get a block in the Hesperkinji from MI unless if it's a massive MI. And because of that, it is unlikely, once you see it, it's unlikely to recover with revascularization. AV block, as we said, we are trying to respect that terms about the delay, or it's an interruption. It can be transient or it can be permanent. But atrium is talking, this communication is not reaching to the ventricle because of the AV node or Hesperkinji. And there is different types. Congenital AV block. Honestly, in my training, I saw one or two cases. Later on, I have another one or two. But since we started doing the missions, for me, and we're having that the clinic, the arrhythmia and device clinic for back in Syria, I've seen probably so far 7, 8 cases. So I never realized how it's important and in common problem. It's about in 1 in 15,000 and 1 in 22,000. And neonatal lupus is one of the important responsible disease of that congenital complete AV block. I guess that's probably more in the US, and I think that likelihood on overseas is different. It's so important pattern to recognize because patient might not be aware, or you are a physician is not aware, and it's like the patient is 10 or 15 years old. Typically, they're not symptomatic. Another important types, they're more serious stuff, like and you're having other congenital heart disease. like transposition of the great vessels, AV canal defects, and Epstein anomaly. And it's a common echo board and question. Epstein anomaly is also known of having a right-sided accessory pathway. So these are the two type of question, and they like to show it like, Epstein anomaly has a right bundle branch block, but when they have an accessory pathway, your QRS, because you're reaching to the right ventricle, will be narrow. Acquired AV block, number one is the drugs. What I mean drugs by that's like medications. So you have the digoxin and beta blocker. Their effect is indirect on the AV node by affecting the autonomic nervous system. Versus you have the calcium channel blockers, the one like a diltiazem or verapamil. They actually directly slow the conduction of the AV node. Same for amiodarone, which honestly, amiodarone has multiple different mechanisms. Type 1 and type 3 antiarrhythmic drugs can also affect the conduction of the His-Purkinje system and cause infranodal block. However, to develop that, you typically have a problem. You're just making it worse with the medications especially with the type 1 and type 3 medications. If you have a normal conduction on these people, it's unlikely to develop a block using antiarrhythmic medication. The other common reason we mentioned is the acute MI, and about 12 to 25% of all patients with acute MI, they might have heart block. The more serious one are the less likely one, but first degree, about 5 to 10%, second degree, about 2 to 5%, and similar for the third degree. And inferior MI, this is when your AV node are the most one affected, and this is the most common types of infarct. As we mentioned, having a Mobius type 2 or His-Purkinje system block, that usually a massive MI. And for the inferior MI, due to the RCA infarct, and usually it will respond to atropine and catecholamine stimulation. So that's one of the distinguished marker. As we mentioned, just a couple of minutes ago about, you can have a complete heart block with the anterior or inferior acute MI. And again, it will be the AV node, but the patient who develop it in the level of the His-Purkinje system from anterior MI, they also can more likely to have a VT-VF. So let's say if a patient has a complete heart block, and even if his EF was 40% and it's persistent for, AV block, so it's not like the answer will be like a CRTP, also consider a CRTD in this group because they're more likely to have a VT-VF. But again, it's not necessarily on the guidelines, but this is something you keep in mind. Other common reasons is probably more in the West. Ischemic heart disease and the chronic. Again, personally, I did not see I did not see like somebody, I revascularize chronic RCA CTO, for example, and it will recover. Degenerative disease are the other most common type, to be honest, that we see here. It can be an acquired cases. I'm sorry, it's one of the most acquired type of AV block. Again, you see usually calcification of the aortic valve, calcification of the mitral valve, is an elderly population, is a tear and wear over the years of that His-Purkinje system. Rheumatic disease are a common reason. Infiltrative process like amyloidosis and sarcoidosis. In sarcoidosis is the common patterns where you see both, you can see a VT and AV block. And that's why they're commonly, when you need a pacemaker for sarcoids, you get an ICD with it. Another patterns important to recognize is the neuromyopathy, myotonic dystrophy. I don't know how common in different countries, but they can have the common disease of you're seeing a first degree AV block, but the problem is happening in the Hesperkinji. So you typically have a left bundle, your HV is prolonged, and these patients will need a pacemaker, even for the first degree. But usually you have an EP study to confirm again your HV is very prolonged. Infection like infective endocarditis, um, that means usually an aortic valve abscess, and it's a serious problem. Again, the treatment beside the surgery, later on, we will need a pacemaker, whether it's an epicardial or endocardial. Iatrogenic is every time, I think that number will go up. It used to be after cardiac surgery and typically the aortic valve replacement or repair of congenital heart defects, which we see a lot, actually, I see in Syria. It could be an ASD repair and the patient is in a complete heart block after that. But typically will recover, but there is a good percentage they will continue. The most common type that we see nowadays is for us TAVR, trans aortic valvular replacement. That number has not changed. It says like 10 to 20%, and it's still high. And its only difference now is, are we able to detect it earlier or later? Because there is more tendency about next day discharge, and then we discover in a week later they have a complete heart block. But the percentage has not changed, and there is a lot of work still going on of how do I avoid it. And there's the other common types, like, we see it even for us as an EP, in cardiology, if they're going to do it for right heart cath, if they're going to do a biopsy, and you have a left bundle, you hit your right bundle, you have a block. If you're ablating in an accessory pathway that is septal, rarely for AVNRT, and, for the left side, it's usually deeper. So it will require more work from you to achieve a block from somebody with a right bundle. But if you are doing TAVR and you have a right bundle and you add a left bundle on it through that TAVR, then you're more likely to develop, of course, a permanent heart block. And that's one of the highest risk group with the previous old right bundle and the TAVR patients. There's the acquired AV block. A pattern to recognize is the vaguely mediated AV block. The most common type is both, you see the sinus and the AV node slowing. Very important pattern to recognize. A lot of consults we get like that. You see both happening. The AV node is now, instead of the rate of 70, moving to the 30s, and the AV node now is also blocking. It has to be something on the top slowing both. It cannot happen two incidents at the same time. There will be some cases of they're vaguely mediated and the level could be blocking the AV node or the sinus node, and they're really tricky. And you have to have a very good history, good evaluation to distinguish between them. Long QT, I've seen in all, in the last 15 years, one case where very prolonged QT actually caused 2-to-1 block. And it was symptomatic severe bradycardia. So these are, but, so we discussed it's the congenital or acquired, and we mentioned about the examples of it, and we said it's AV node or Hesperkinji. Clinical presentation is a very, very important determinant factors of what is the next treatment, for this patient. For example, the congenital AV block, patient is asymptomatic, narrow QRS, active, delay the pacemaker as much as possible. It could be you can wait probably 20 or 30 years old. And, as long as no issues, no problem. I mean, I have 2 patients pregnant, and no issues, and they're active and they did not need a pacemaker, and you can delay it and avoid the complication of a having a pacemaker at a young age. But the symptoms as well, it could be you put him on he cannot walk. He's at, like while he's sitting, he's fine. While he's going to the bathroom, he's fine. But beyond that, going upstairs, it can be symptomatic. So these are some of the symptoms. First degree, as a rule of thumb, they're usually not symptomatic. However, in particular group of patients, weak heart, very long PR, above 300 milliseconds, you can create this synchrony and an atrial contracting and the valve are already closed. Similar to that, like kind of a pacemaker syndrome. So in this group, which pacemaker syndrome is usually when you see a lead sitting on the RV, on the ventricle, and no atrial, and the A does not communicate to the V. Like you're switching the lights and the light is active when it's on. So in this group is sometimes you might end up, again, very careful about having a need for a pacemaker. It's all now the natural history of AV block. It depends completely on what was the cause for the AV block. As we said, RCA infarct, you recovered, it's gone. Valve surgery, you said wait for 5 days, and then if it did not recover, you end up with most likely a device if it's complete heart block. But most of the time, by that time, it's recovered. Now, the other pattern that you see, and electronic medical records help a lot. You will see in degenerative disease, it starts, for example, in a first degree of a PR like of 220 milliseconds, then it progress over the years, to 300 and then 400 or, 2 to 1, Mobus type 1, and then the complete heart block. And you can see that over the years. Having a right bundle, this left anterior and the first degree is a higher risk of a complete heart block, but it might take several years. Left bundle are more likely to develop later on a complete heart block than right bundle. So there is a different patterns based on each, the etiology, in other words, and the progression varies between the group. How do you evaluate for AV block? And what do? You need to have a very good history. Like some disease, like a Lyme disease, for example, is an infection that you say, oh, it's a tick bites and recovered. And the clinical presentation, is the patient presented with syncope? Is the patient presented with, extreme fatigue, out of breath, um, and a very faint pulse? It will change your management. Physical exam, of course, we look at what the heart rate and everything. But, I mentioned here, I listed the carotid massage. It helps in distinguishing if it's for example, a 2 to 1 block. Are the problem is in the AV node or are the problem in the Hesperkingi system? And that's like really the second half of this presentation is to talk about. But Hesperkingi system, you slow the sinus, you slow the AV node, your conduction will improve. You increase the sinus rate, that means more beats hitting on your Hesperkingi system, that means worsening of your AV block. EKG is extremely important, to evaluate the patients. Again, what was the escape rhythm for the ventricular rate? Is it, a PR very prolonged or not? Is the QRS wide or not? To direct you in one way versus another. If you saw a PAC, is it conducting? How was the block pattern? And exercise testing, it's one of the cheapest way as well. You make patient even in the clinic move back and forth, get an EKG, and you will see is it worsening or is it improving. Sometimes even people who's like in the hospital and they're laying in bed and just moving your arm, you say 40, 50 times and see what happened to the rate. Is it worsening or is it improving? Non-invasive monitoring, Holter, which we've been using to more like sometimes when you don't have a treadmill, unfortunately, so you can use it and you can tell the patient you exercise and we'll review your Holter. An event monitor and implant loop recorder, which have been using sometimes as an event monitor. Invasive testing, like an EP study, is usually not required. It's rarely really, I never have, I don't know, probably every 5, 6 years, and you do it more for the academic purpose, with your EP fellow, you're trying to show him like why you suspected the level of a block, for example, infra AV nodal. Or it came a lot of popular during the TAVR now area, but you know, if it's positive study, I think it's helpful. If it's a negative study, it's not helpful, and these patients still get to monitor. All right. So there is a typo here. So that patient has a PR of 280 milliseconds. His AH is 196 and HV of 51 milliseconds. And for these kind of questions, and there is the EP portion, we jump to it to the AH and HV. But really, they wanted to focus about the service EKG because most of the time the answer is in the service EKG. The rest is like a nice addition, but I'm not having my catheter all the time. So, and sitting with the heart. So it's really to translate what the EKG show, but the EKG will give you the answer. And before I'm start to get to that answer, if if I'm gonna say the PR has three components, which is how we decide the first degree or second degree. The time from the sinus node to reach to the AV node. So that's the P times. Then the times from leaving from the AV node to the Hesperkingi system, and that's the AH time that you see here on the Hes. You know, and then the times from the Hes to the QRS, and that's on the service EKG. And that's what we call it the HV time. The component of the three is your PR. In other words, if you see a PWF, could be the PWF is very prolonged, for whatever reason. And, your AH could be normal and HV could be normal. The problem is in the atrium. It could be the AH is very prolonged, HV is normal, AA timing is normal. The problem is in the AV node. And again, the HV prolonged, the rest of the values are normal. You can still have first degree, and the problem is in the Hesperkingi. And the management is completely different. So in this case, any volunteer, you know, and AJ, feel free to pick, or if not, I will keep going and explain in the example for each one. Hello?
Do we have any volunteers from the crowd? Anybody?
So we have a
Maybe,
PR of 208 milliseconds. Go ahead.
No, go on. Sorry.
So we have a PR of 200 milliseconds. So we know there is a first degree. The AH is, the normal is, 55 to 110. So we know it's prolonged, and HV is normal, is 45 to 55. And the QRS is narrow here. So, the diagnosis was, it's a first degree, and the delay is in the AV node. Okay. Now it's a different example. And again, the PR is the same. And actually, this is a patient with myotonic dystrophy that we mentioned. So the PR is another 280 milliseconds. If you look at the service EKG, it's a very generous left bundle branch block. If you look at the AH timing, we break it down. It's 120 for AH, and HV is 125 milliseconds. And usually we say above a 70, most likely needed for a pacemaker. Above 100, nobody even will discuss it. So big problem in the Hesperkingi system. So the level of a block in this patient is in the Hesperkingi system or the delay. And that's why it's so important to recognize. And that's why the myotonic dystrophy patient are more likely to need a pacemaker because of that. Any question about that?
So obviously, it's really helpful when you have the ability to do an EP study. So in cases when you can't EP study these patients, so there's ways you can evaluate an EKG to to determine this, or do you have any suggestions in those patients who were
True.
in? Yeah.
Yeah, so you're absolutely correct. I mean, I think some cases are tricky, like that is myotonic dystrophy, right? Or the TAVR, and you're trying to figure out what is the problem. Um, I think all honestly, looking at the old EKGs is very helpful. Like if what is the progression? What is happening? Is the QRS was always left bundle and now I developed the PR, it's just prolonging slowly, then it's very helpful. If I look for a PAC that is really not very early, you know, let's say it's like, I would expect it. If I have a good um, AV node, because it will just prolong more, for example, I will expect it uh, to improve, to conduct. But oh, I don't see it to conduct. I would be very nervous that I have a Hashimoto system who could not handle that PAC. I could be walking on a treadmill as well, like auto halter to get the answer for that. So the non-invasive will guide me. And again, the type of the disease, what this patient has. So that will be my approach on this population. I don't
Okay,
know if I
fantastic.
answered. Yeah.
No, no, I think that's great. Yeah, because there's, it's always nice to have other ways to review these patients, especially.
And now
So they
to
usually
this. Yeah,
you usually
go
see
ahead.
them as progressive, right? So even in these cases where it's first degree, but it's HV, the next step you typically see some sort of 2 to 1, some sort of, or
Yeah.
um, or does it sometimes go straight to CHB, do you think?
So AV node are will take longer and it will show decremental. That's the patterns. And decremental meaning PR getting longer and longer and longer. Versus the Hesperkinji system, they do not have that pattern. So usually any prolongation will be minimum. It will be jump. It might jump from 20 to 30 to 40 milliseconds, but that's it. It cannot handle a jump of 50, 60, 70 milliseconds, something like that. That decremental patterns is the unique part for the AV node.
For the AV nodal. Okay.
Yeah.
So if you're seeing it, especially under exercise, go to a 2 to 1, um, that probably indicates some HV issues.
Yes, yes. And hopefully I'll show you a good example about that.
Perfect.
So here, and that's the tricky part about the service EKG that I would, want to point here. When you have a lot of scar, patient has a maze, to open heart surgeries, all these extensive ablations, your PR might look normal on the service EKG, as you can see in 2-3 AVF. But the reason it's looking normal, there is still a lot of atrial tissue. You can see here this HRA, high right atrium, mid left atrium, is all scarred, that meaning it's not fully scarred, but it is not big signal enough to be recognized on a service EKG. And that's why it looks like a flat line, but really it's not. And now you say, oh, if I gain it and it's big, now I have a PR of 450, milliseconds. That's the scale here of 400. You're discussing 400, 500 millisecond easily. But the problem is not in the um, either in the EP node or could be the Hesperkinji. It's all in the atrium. And this is why the patient can still have tachycardia later on because it is not the AV node. The AV node is healthy. So you put them in AFib, yeah, I mean, it will still hit the AV node. And you say, how come I have a PR of 500 milliseconds and the heart rate is 50? I would expect now with the decremental more, I will expect, or Hesperkinji cannot handle, I will expect it much worse. But the fact is, no, it is all atrial disease tissue. So if any times I don't need it all the time, like an AFib area close to the AV node, I will be able to conduct and and you will be on tachycardia. Um, so this is an example of clinical evaluation. This is a 60-year-old presented with fatigue. Um, so it's hard to see, but it's sinus. And if you look at lead 2, you will see sometimes a hump on that T wave. I mean, if somebody willing to take, I promise I will not be, we'll walk through it together. So feel free. But you can see there is on the T wave, it looks funny, as EP likes to call it. It looks funny. That funny is there is a P wave hiding in it. And so what? I mean, it's like, all we all have fatigue. I don't think I have a day without a fatigue. Am I gonna have the pacemaker of the PR? So you want to make sure is this fatigue is due to the AV node disease. So the best ways to evaluation, again, if I see that PR and I know the patient never have an open heart surgery, something for me, or ablation extensive to suspect atrial tissue disease, I have to suspect AV node. To test the AV node, as you mentioned, you put them in a treadmill. Um, for this
And from the
treadmill,
chat,
yeah,
one of the first statements on the last EKG was it looks like first degree block.
that is correct. Yeah. So now, what do you guys think about this treadmill EKG? Any volunteer?
Anyone in the chat have any thoughts on it? So the R to R interval becomes kind of inconsistent here. It's
Yes.
very noisy EKG. Do you?
Yes.
Uh,
Noisy for a purpose, you know.
okay.
Honestly, because it's the real life. I mean, we want to have the most smooth EKG, but the
Yeah.
reality is we don't. The patient is moving. You have the
Hmm.
hair. You have, it is. Sometimes even when EKG fails. But the thing is, this is when you're gonna not get closer to the EKG. Actually, you're gonna move backward, and you look at that EKG and you say, "Huh, I see a pattern." you
Hmm.
know this is here is getting closer, and then you drop, and then you see the same patterns, this group beating, the same exact group beating. you know you see here the longer, the shorter, and then back longer, the shorter, that back longer, the shorter, and the same pattern. you know exactly group beatings. So without even knowing, you know anything you said, this has to be Mobius type 1. This is, that's the group beating. It's another QRS. It's the same pattern. And I know that even the story of that patient, he has a very long PR. So when I put him in treadmill, he's already barely able to handle that particular heart rate. I don't know, it's close to like 80s, high 80s and low 90s only. And he's very symptomatic. So, a good discussion with the patient. Some of them feel like, I'm okay, or some will say, no, I'm miserable and I need to have a pacemaker. But that's why, because it's not all the times the PWF will be able to see. So we discuss, that first degree, the AV delay. I think the last treadmill takes me to the second degree, because, most of the time they will cross from first degree to the second degree, and you see an example of a Mobus type 1. And um, you have the two types, Morbus type 1 and Morbus type 2. Morbus type 1, prolonging, and dropping. And the other one is all of a sudden dropping. And we'll use again an example here. I'm not showing necessarily the easiest, but, the logic is, you need to think, is this is a serious bradycardia? Is this is a serious block? Or this is, I'm okay. We'll evaluate the patient as an outpatient or no. So it's an EKG. You can see the right bundle. You can see probably there is an old inferior MI in the 3 and AVF. And if you said, I'm looking at this PR versus that PR, when you don't have after that the P wave drop, you have a prolongation, right? I hope you guys agree. Same here is a short PR. The next one is longer. The next one is longer. Correct? So it is by EKG criteria. That's why it's not important for me as an EP completely. It is Mobus type 1. Mobus type 1, we all taught not to worry, not to do anything. Okay? have my disagreement, and I will show you why not soon. So as we mentioned, AV node is able to decrement significantly. We're discussing 40, 60 milliseconds decrement. Yes, it's obvious, but that's why we miss it, because it's not significant. It's obvious after you carefully look into it, but again, we all agree it's not significant. So this minimal prolongation resulting in a block after that, that's a behavior of his Purkinje system. That's not a behavior of AV node. You add on that, of course, the right bundle. But I'm also want to focus here. I want to zoom on this beat. And you can see that right bundle is even different. Again, after you conduct the first one, this right bundle is really narrower. So you can tell something hit my Hesperkinje twice, you know, from this minimum prolongation and immediately developing this full right bundle of very similar cycle lengths. So all would point that this is a Mobus type 1, and the problem is in the Hesperkinje and not the AV node, and a patient will need a pacemaker. Don't believe it, you put a monitor, you will be called with this. And that's what this patient has. You see the P waves walking around and, needing for an urgent pacemaker. So it's a focus again, Winky back block or the first degree Mobus type 1. Uh, Start to suspect that how much your PR prolonging. Is it short, minimal prolongation or not? Do I have a wide QRS as baseline or not? Wide QRS, minimal prolongation and dropping. After that, suspect it is Hesperkinje, and I will go with pacemaker, and I will not do an EP study for him. Treadmill is fine. You can put him. Problem with the Hesperkinje, sometimes they will look good. The next day, they're not. They're kind of unpredictable, different from the AV node. Is that point clear?
Yes, sir. Sounds good.
So we're gonna go from here. If we said Mobus type 1, we said the Mobus type 2, and then we say, how about the 2-to-1, which is the common pattern. So we have this patient is on atenolol, 25 BID, complaining of pre-syncope and syncope, and that's her monitor. We have it's clearly on the tops, it's 1-to-1 conduction, and on the bottoms is 2-to-1 conduction. PP is fixed, the PR is fixed. So there is a relation between the P and the QRS. I think a very easy to recognize observation is the PR is short. Single lead, you might be able not to tell if it's a narrow QRS or a wide QRS. But that's why we call it 12 lead EKG. We want to see the 12 leads. But the PR is short. The PR is short. And we mention it, and it's always to remember AV node, if you have a problem, you are going to expect to have a longer PR. His Purkinje, if you have a problem, you will expect a short PR. There will be, unfortunately, large area in the middle. And to say, I cannot tell because that number is in the middle. It's not short PR, it's not very prolonged PR to give me the answer. But I think I'll show you the EKG very soon. And as we mentioned about the Hesperkinje system, you could be fine, and all of a sudden it will fail on you, and you have this high degree AV block or complete heart block for several seconds. Fortunately, it came back on that patient. So you might be looking good. It's 2-to-1. I'm okay, but that's what the unpredicted patterns of that Hesperkinje. Versus AV node, you will not have that. So this is a patient. This is actually that same patient, and so I have it a little bit in a different order. And basically, this is the baseline, and again, it was the symptoms, and that's the PR. is short and right bundle branch block. So somebody wanted to test that patient. And we see it first with the treadmill, stage one, at the beginning of the exertion. And, heart rate picked up. I don't know, it's closer to 100. Everything looks good. And the PR has not changed. Then stage two, that means more exertion. More exertion, and back to your question, AJ, about what we're gonna see on a treadmill, it is the opposite here. All of a sudden now I move from 100, or 110, I'm supposed to reach 120, I go to 60. So what's going on? And again, it's very noisy, but that's the real life. But I know for sure I can see where's the QRS. I can tell it is regular, and I can tell it was 100 just a minute ago. And I tell the patient, now you exert more and you are slower. There has to be that means it's 2 to 1 block. 2 to 1 block. Again, with the PR, no prolongation before that. I have to say this is 2 to 1 with the level of a block, infra AV nodal. Here, start resting again, and the heart rate picked up. Again, another confirmation. AV node is able to handle up to 110, for example. Not AV node. His Purkinje is able up to 110, 120. Beyond that, he's like, this is too much. And he goes to 2 to 1. And that's what we have it here. Even on the monitors, um, when he goes to 2 to 1, if you notice here, the P wave is also fast on that patient. So before that recovery that you saw of 1 to 1 conduction, that's earlier. And again, you will see the 2 to 1 now nicely. The noisy one that I was trying to show you, and I said, I want you to guess that answer because it's not always going to be smooth like this. But you can see at the end of the T wave, the negative portion, this here. So it's 2 to 1 block. In fact, it's only showing you in almost the most lead here in AV F. Other leads is hidden on that. Actually, not AVF, I'm sorry, in V1. In V1. But the other leads is heading on the T wave. Again, how we say it, T wave doesn't look good, but it can be tricky. Um, Actually, this I should have it earlier, but this is now it's a different way. This is a Mobis type 1, and this is Mobis type 1. And you see it here on the service EKG. That's the P QRS, and then P QRS, and then again, on that T wave that look funny. Look in lead 1 and lead 2 and 3. It looks funny. And again, no conduction and back here. The other important pattern to recognize, your QRS here is right bundle, it's here left bundle, and back right bundle. So this alternates, this PR prolongation in this, and you have that change all in HV. So when you have that prolongation in the PR that much, you typically get as well a change in the QRS morphology for the Hesperkinje system. So site type 2, second degree AV block, it is what we described, like, that's the transition. So we move from Mobis type 1 to Mobis type 2, and you have on the 2 to 1 block, and the majority of the time, for the type 2, it is infra AV nodal. I'm showing this example since I show you the alternates of the EKG. This is a patient who has a TAVR 3 days earlier, narrow QRS before that, permanent AFib. But again, a pattern to recognize about the Hesperkinje, right bundle, left bundle, and here you can even have back intermittently narrow. But a pattern is recognized that this can progress, which it did that patient and worsened for that for his conduction, and we put a pacemaker for him at the end. This is a patient before TAVR, PR, relatively prolonged, but not very prolonged, narrow QRS. 5 days after TAVR, has a problem in both AV node, because your PR now is, I don't know, 450 milliseconds, and it's a left bundle. So you have damaged both the AV node and the Hesperkingi system. And these patients, by the guidelines, will require pacemakers. Again, this was even 5 days after TAVR. And we mentioned about the 2-to-1 block here, you know, and I said focus about the PR and the QRS. So the rule of thumb, if your PR is 2-to-1 and it's less than 160 milliseconds, you are almost always you're dealing with infrahessian or intrahessian block. If your PR is very prolonged, it's more than 300 milliseconds, this is an AV node disease. Unfortunately, many cases will be in the middle. But believe me, I'm sure we all, have cases. I have it multiple times. Literally 2 weeks ago, I have 2-to-1, less than 160. And in the case when we're even pacing the A faster, it was already, P wave with no QRS whatsoever. Narrow QRS versus wider QRS, helpful, but not the most important. The most important is the PR. Um, and again, it can be tricky sometimes, the PR, if you have previous surgeries. But if not, this is the magic number that came with the studies. Wide QRS, and you have short PR, like Our Lady, the one I show you, the 2-to-1 with the right bundle, it is usually in the AV node. I'm sorry, in the Hesperkingi system. The opposite, long PR, narrow QRS, like our patient here, you know. So it's 2-to-1 block, very long PR, narrow QRS. It is AV node. You can relax. Here, again, it's hidden in this funny looking T wave, 2-to-1, short PR, and you have this kind of right bundle branch block, and the level of a block is in the Hesperkingi system. Any question?
And once again, folks in the chat, raise your hand if you want to ask a question verbally. Feel free to type it out in the chat. So I have a question. This is less about more proximal blocks and more distal blocks, I guess is what I'm thinking about is, so when you have a patient in complete heart block with wider complex versus a more narrow complex, a lot of times folks are more concerned about the wider complex patients. Is that just because there's less options within the conduction system to take hold if that focus was happened to go out, or what's the reasoning behind that if you have any?
So every time it's like the Hesperkingi, if you're coming from a higher level, your rate will be faster and it's more reliable, stable rhythm. You go down, so like if in the distal Hesperkingi, this is becoming slower and less reliable. You pass the Hesperkingi system, now it's ventricular escape rhythm. So it's not looking like the typical right bundle or the exact typical left bundle. So it's not coming from fascicle of the Hesperkingi. It's coming wide QRS, 35 beats per minute, but I can tell based on the previous patient EKGs, based on this is not a Hesperkingi system rhythm escape. That rhythm, unfortunately, is less reliable and slower, and skip beats, even a BVC, couple of skip beat BVCs, he can be going now. You suppress this automaticity for this area, for that foci, and now you don't have any skip rhythm. Versus for junctional, we see it all the time. When we test our pacemakers, I put the pacemaker, the escape rhythm is 50s, it's narrow. You tested him like a little bit faster, 60 or 70, and then you're good. It's like, you stop pacing, it take a couple of seconds, but it kicks in. Versus this one with the ventricle, it will come with no escape rhythm. Like it's done. That's why many times, we might end up putting two leads, like some for stability till you have the right spot with a good injury and everything, or you can put temporary pacemakers because you know that this rhythm is unstable. The minute you start testing it, the minute your leads maybe even hit it, and you have short runs of, non-sustained VT, 3-4 beats, that's enough to suppress it and you don't have escape. So that's the reason behind it. Um, I'm showing this example. Again, it's rare, but it's important to recognize. And it's a patient that, again, I have it only one time. A 66-year-old, hypertension, diabetes, echo LV function is 45 to 50. EP study done to make sure it's not ventricular arrhythmia. And I just want to let you focus here on pacing A. This is your HRA and then the HIS. But you can see that HIS has a split, this and this. That split, you can see it for the next beat with my arrow. Again, it's bigger. It's bigger here, you know, that's your pacing spikes. And then you have it without the A. So again, back again to it here. That split HIS. Less obvious here, but again, the block, you have here. So that's the split here. That's you have one portion, you don't have the second. Here the split. Again, here you have the one portion, you don't have the second. Again, it's the split. Versus I show you multiple examples of his Purkinje system, you know, I don't know, should look like this. No split. So that's your A of the HIS and that's your HIS. So very uncommon. And probably that's the most part when the EP study is helpful. But you need to be very detailed oriented to catch that split of the HIS. And the treatment is pacemaker for that patient. A high-grade AV block, it is not 2-to-1 block. It is not complete heart block. It is something in the middle. So it could be 3-to-1, 4-to-1 block, but it's not, P are talking to the QRS at some point. Maybe it's like, an EKG terminology. Maybe it's not that important, when it comes to putting a pacemaker, but you're gonna have, you want to read the EKG correctly. So if I see like, an intermittent complete heart block, but there is some intermittent conduction, you're gonna have to say it's high grade AV block. So again, there's a pattern here. You see here the alternates. If you look at the V1, you have the right bundle, the left bundle. You have 3-2, here and a conduction. The PR relationship is fixed. See when it's conduct here, it's conduct here, it's conduct here. That PR is not walking, randomly. Same when it goes to the right bundle, same when it goes to the right bundle. Again here, your PR has a relationship to the QRS. You have an alternates of the QRS for left and right, and you have, different degrees of AV block. So that's all high-grade AV block. The third degree is no relationship. The A is walking separately and the V is walking separately. And important pattern, and then the escape rhythm, we said it could be, if it's coming from the junctional from 40 to 60, below the junctional, it becomes wider and slower. And important to recognize between it and the AV dissociation. So complete heart block is an AV dissociation. The VT is an AV dissociation. So you can feel like the true extreme. So if your ventricular is faster than atrium, they're not going to talk together. And, for example, if you have a junctional running at a rate of 60, junctional tachycardia 60 or 70, a little bit faster. And then you have a sinus node of 50 beats per minute. So you say, oh, I'm in a complete heart block. No, you're going to have to see enough time for the sinus node, enough time for it to conduct, and it's not showing conduction, and then you say, I have a heart block. But if you don't have that enough time because your ventricular was faster, as I said, I'm using the example of the VT, that's why you're not conducting. It is not because you have a problem of the AV node. So we call it AV dissociation. Um, so this EKG, what do you guys think? Is it a complete heart block or it's AV dissociation? I'm sorry, is it high-grade AV block or is it complete heart block? Again, it's just for the EKG. I mean, I don't think any of us as an EP will say, yeah, he needs a pacemaker, you know? I mean, that is for sure. But if I said the PP is fixed and the RR is fixed, and now I'm going to have to read this EKG correctly, is it a complete or is it a high grade? You know, meaning like 3-to-1 conduction. And you know, I mean, like, okay, give me my caliper, give me all of that stuff, and I'm saying it's all regular. So if you look the relationship for the P waves to the QRS, you know, you can see it here is happening later. Because later is pulling in, pulling in, pulling in, and here is disappearing. So you know there's no relationship. So that has to be a complete heart block and not 3-to-1 block. Um, this is here. And what do you guys think is going on here? So narrow QRS, some P waves, some no P waves. Um, so this is narrow QRS, and you can see on the inferior leads are negative, 2, 3, AVF. And, you know, so it's junctional with very severe sinus
Functional with the,
tachycardia. What?
yeah, is that retrograde in the junction?
Yes, yeah. So it's
Yeah.
retrograde with junctional. Sinus rays picked up. You know, is it conducting or I'm not conducting is not clear. But now the retrograde disappeared. So this is reaching at least the AV node. Same here, because otherwise I should see some retrograde here. And here, now this is why I said I just give it enough time. My RR is shorter. And that's the only one I'm very certain, at least I have a little bit of enough time that, you know, even with that little time, it was enough to pull the R waves. So if I said, how is my AV node? I said the AV node is good. It's conducting, you know, at least at that level rate. And I have an escape rhythm. It's good. I'm not in danger for that patient. And I said I have a significant sinus node dysfunction. If I put him on treadmill and his sinus node is not picking up adequately and it's all junctional rhythm, then I know it is a problem and this patient will benefit from pacemaker for symptoms relief only. Um, it's kind of very similar to this patterns, but here is a little bit maybe I think obvious. So here again, it's a complete heart block. PP is working and the QRS is regular, no relationship. But I want you to recognize that patterns. You see PR is very long. You have here that P wave in the inferior leads negative. It's retrograde. You see it here. You see the retrograde. Still, now we got closer. Now we got closer, and now I don't see the retrograde. I don't see the retrograde. I don't see the retrograde. So that means I'm reaching to my AV node. That's why I don't have the retrograde. So you can have an antegrade bad, but the retrograde is still good, like this patient. You know, it's always going retrogradely here. I have a very solid retrograde, and my antegrade is bad. That's when I do like some ablation for AVNRT. I don't like to see the junctional P to the retro. I'm worried about the antegrade. So I do it, and I look for pacing of the A to see, make sure it's conducting 1-to-1. But
To
this
con
is,
to confirm here, you're not seeing the retrograde because you're reaching, you're actually blocking retrograde. Is that what's or the eight? Sorry, it's no longer accepting the retrograde impulse, essentially, right?
yeah, because it's gonna go retrograde, but your AV
Mm.
node is still refractory from the
Mm.
antegrade conduction. And so that's the reason, and that's why, because here you actually, it's your AV node recovered, so you have very long PR, AV node recovered, you were able to achieve retrograde. Here your
And
AV node still did not recover, it's still refractory, and that's why it did not conduct.
For our device nerds here, that can be troublesome with PMT as well, right? So you may think, okay, they don't have anterograde conduction. We don't have to worry about pacemaker-mediated tachycardia, but you can have retrograde conduction with no anterograde. So always keep that in mind if you have patients complaining of palpitations, that you have the EGM saved, stored to look for PMT because it can happen.
Absolutely. I mean, that what you describe as saying, "Oh, I'm having complete heart to block," and then you say, "Huh, how are you going to have a BMT?" Yeah, because the integrate has nothing to do, to do with the retrograde. You can have a construction on 75 on the freeway here north, you know, but the south is working. There's no construction on it,
Mm,
and these are the most tricky and challenging patients because every time you pace on the V, you can have a retrograde A, and then you start following it. And of course, it's always I'm with the patient I have the worst one was actually a lawyer, and you have to go actually and ablate that retrograde conduction was the only treatment. It's showing you the same, basically what we're talking about. That's the last part. I think that's the last EKG. Um, you know, you don't have an antigrade because of um, just the sinus node dysfunction. But you can, how we said about Mobis type 1 and all of that stuff, you can have Mobis type, uh, you know, 1 retrogradely. Again, that's why I said it's tricky about when you see the retrograde, and this is why it's an important pattern to recognize. So here you can see QRS retrograde tiny here. Here is pushed and then it looped, you know, and then again here, this is uh, the junctional. There was actually a P waves coming in. Again here, junctional retrograde, loop back. And this is
mm,
here, the sinus wave came in, and that's why you don't have at the end here, but there was no retrograde. So that Mobis type 1, Mobis type 2, all of this, it can be antigrade or retrograde. That's one. And number two is this is when you start to see sometimes while you're testing pacing, for example, V pacing, and then you will see what happened here, why this conduction is coming. It could be basically just looping back. Last slide, principle of management. As my interventional colleague told me, if it's slow pace, and it is true, but I need to know when to pace, how urgent, is it based on symptoms? Am I going to tell the patient I'm only doing it for symptoms? It's not life-saving, or I'm doing it because it's life-saving, even so the EKG does not look bad, to me. It's only 2 to 1. It's only Mobis type 1, but really the level of a block is below the AV node. Um, some conversion pauses, I think, you know, it's a different topic. The conversion pauses below 3 seconds, we don't even ask about it. More than 3 seconds, you need to have the symptoms. We always keep increasing that conversion pauses. Are we talking about before it used to be 4, then it's 4.5, 4.5, but they always focus, do you have symptoms or no symptoms to decide about needing for a pacemaker after conversion pause. Obviously, if it's 7, 8 seconds, even the patient said, I don't feel it, you know, if we're all laying in bed and we have 7, 8 seconds of pause, most of us might not feel it. If I fall asleep, but it could be a conversion pause. That's it.